This educational webinar follows the announcement by the U.S. Food and Drug Administration of a PMA approval of the Impella technology for expanded indications. After extensive review of the data, the FDA has determined that the Impella platform of products, the Impella 2.5, Impella CP, and Impella 5.0 are safe and effective for the treatment of cardiogenic shock and heart recovery in the setting of acute myocardial infarction and post-cardiotomy cardiogenic shock. Previously, in March 2015, Impella 2.5 received a similar distinction with a PMA for protected PCI. Guidelines from multiple societies have incorporated mechanical circulatory support, or PVADs, into recommendations in selected patients for hemodynamic support in a variety of settings, including PCI after STEMI in patients with large amount of ischemic territory and poor left ventricular function, and use of PCI in non-SOS hospitals for high-risk patients. There's also guidelines from multiple societies on acute heart failure settings with and without concurrent PCI for patients described as acutely decompensated, patients with multi-organ failure, profound hemodynamic compromise, and cardiogenic shock. Therefore, the announcement by the FDA of this PMA status for the Impella platform in cardiogenic shock harmonizes guideline statements and the FDA's regulatory oversight for Impella. Impella is the world's smallest heart pump. It is placed most commonly via the common femoral artery in retrograde manner across the aortic valve and has a variety of features that would be desired or considered ideal in a mechanical circulatory support system used for the treatment of cardiogenic shock. Impella's ability to be rapidly deployed by cath lab and surgical teams early in the management of cardiogenic shock results in multiple useful goals for patient stabilization and myocardial recovery. First, robust ventricular unloading. Impella effectively evacuates blood directly from the left ventricle, unlike other devices which may load the ventricle or provide little unloading. Second, equally important, Impella provides end organ perfusion by increasing cardiac output to brain, liver, kidney, and other vital organs. Third, left and right ventricular support with the Impella family can now be provided. And fourth, the Impella family allows selection of the appropriate level of support initially and provides a pathway for escalation of mechanical circulatory support when needed. Alternative access sites for Impella are being used which permit ambulation that allows patients who need longer support to be ambulated and recover. The Impella heart pump works by withdrawing blood from the ventricular cavity and ejecting the blood into the aorta. Death in patients with cardiogenic shock can result from one or more of these factors: hemodynamic deterioration, occurrence of multi-organ dysfunction, development of the systemic inflammatory response syndrome. Immediate improvement of these factors is the goal of both medical and mechanical therapies. Achieving these goals through improved cardiac output and the potential benefits that may result from avoidance or reduced inotropic and vasopressor therapy are beneficial effects of Impella use in cardiogenic shock. Achieving these goals through improved cardiac output and the potential benefits that may result from avoidance or reduced inotropic and vasopressor therapy are beneficial effects of Impella use in cardiogenic shock.
Cardiogenic shock, as you mentioned, has been a real vexing problem for years, and we have not made very much progress in its treatment, I think, until perhaps recently. I think it's important to recognize, though, and here's the classic Goldberg paper from the New England Journal, really showing over several decades that the incidence was actually stable. But what we've seen recently, and this is from a national inpatient sample, is that it seems to be in recent years, over the past decade, the incidence does seem to be rising. As you can see, going from 6% in 2003 up to over 9% in the 2010 sample. So it is a growing problem that we're facing in the cardiology community. Concurrent with this, there's been a rise in the use of PCI, spurred a great deal by the shock trial. But what we're seeing is, as we're taking a broader swath of these patients into the cath lab, mortality is actually rising. Between 2005 and 2013, in this analysis, cardiogenic shock is actually significantly worse prognosis if you go to the cath lab. Now, that doesn't mean we're doing a worse job. It is a challenge, though, because we are taking sicker and sicker patients to the cath lab. On top of that, we have to keep in mind that getting them out of the hospital doesn't end the hazard. Even though in the long term, at 1 year, the curves do flatten out, what we do see is over the first 60 days, when you compare shock and non-shock patients, there's an incremental hazard of mortality going up to almost 10% by the next 60 days. So if you put this together, we have about a 40% mortality over the first 60 days, which represents a major challenge in terms of our therapies and improving these outcomes. The demographics and who's treating cardiogenic shock is also changing, and this has important implications on technology and the migration of technology. Here we can see that 90% of the patients are being treated actually at private and community hospitals, and only 10% at major academic centers. And concurrent with this, with the dispersion of AMI programs into wider geographies, what we can see again over the last decade is hospitals doing over 500 PCI used to constitute about 70% of the treatment, but we see now in recent years about half of the patients are actually being treated at smaller institutions that do less than 500 PCIs. And that has important implications when we discuss the technologies that we think may need to be available to optimally treat these individuals. We should also keep in mind that when we think about cardiogenic shock, we have to broaden our concepts of how we treat these patients. Now, what we've always said, there was always the lore that if you didn't get adequate response initially by treating the infarct artery, perhaps you should entertain other vessels in patients with multivessel disease. But there was a bit of a reluctance because if you look at the previous guidelines for MI in 2000 up to 2013, it was actually a class 3 a warning about doing multivessel PCI in stable patients. But now, because of recent trials, moderate-sized trials, the weight of evidence seems to be shifting slightly, and at least should be entertained in stable patients, and certainly, I think, entertained in unstable patients with cardiogenic shock. And that means that we need a better foundation of stable substrate in order to optimally treat these individuals. Now, the mainstay of treatment, and probably the initial treatment for any hypotensive patient in cardiogenic shock, will be pressors. And there is a tendency to elevate these pressors while you're treating these individuals. But as you can see here, and this is another classic off-quoted paper by Samuels, is that you can see once you start revving up the pressors, and inotropes. As you can see, once you start getting up, for instance, to 2 high-dose inotropes, your mortality incrementally doubles from 1 high dose and doubles again when you have 3 pressors going concurrently, which means we really have to think about alternatives other than high-dose pressors as a treatment for these individuals. The other mainstay of treatment up until recently has been the intra-aortic balloon pump, which has been around for decades and has been a simple and easy to apply technology. But however, to our, I think, disappointment, the mortality rate in the SHOCK 2 trial, when you looked at IABP as a primary therapy versus a medical therapy as the primary therapy as an adjunct to PCI, we saw absolutely no difference in mortality up to 30 days, with the standard very recurrent 40% mortality in these clinical trials. So that was a big disappointment that a standard therapy that we've been using for decades really doesn't seem to have the effect that I think we assumed it. And moreover, I think the physiology and underpinning of this is evident from this small randomized trial from Germany, which did show that over time when you looked at cardiac power, which is an index, of course, of cardiac output and pressure, when you looked at the balloon pump group, of course, cardiac power did increase, but when you looked at the medical therapy group, it increased equally, and there was actually no difference. So this physiology, I think, gives us the underpinning of why the SHOCK trial was a negative trial. And moreover, and this is from Enriquez's meta-analysis from 2009. When you looked at outcomes in terms of stroke in the balloon pump arm, what you can see here, when they aggregated about 1,000 patients randomized to balloon pump versus no balloon pump and cardiogenic shock, there was actually a significant difference in stroke rates with the balloon pump incurring a hazard, almost more than a doubling of the risk of stroke. So not only does it not seem to be effective, but it does seem to carry with it some adverse effects. And because of that, the recent guidelines for intra-aortic balloon pump in the European guidelines actually makes it a class 3, i.e. a harm. It is not recommended, and balloon pump use in Europe has plummeted accordingly. So I think what we can see from these data above is that AMI and cardiogenic shock is a growing clinical challenge in daily practice. Our mortality rates really have not really improved, and they may actually be increasing as we take sicker and sicker patients to the cath lab. Conventional therapeutic approaches, such as inotropic support with or without balloon pump, do not seem to have improved outcomes, and the ability to hemodynamically stabilize cardiogenic shock patients can allow for more comprehensive revascularization in that population that requires it.
So this really represents an exciting time for hemodynamic support. And when we think about hemodynamic support, the way I like to break it down is, as Seth indicated, is to look at 3 primary objectives for these support devices. The first one is to look at circulatory support, where we're trying to augment systemic perfusion of vital organs. And the measure that we use is a mean arterial pressure, and we should be increasing that mean arterial pressure when we activate a support device. The second part of this hemodynamic support equation is ventricular unloading. And the way we can measure that in the cath lab or in the critical care unit is to measure a reduction in LV systolic pressure and diastolic pressure. And this can also be seen very commonly by looking at a narrowing of the aortic pulse pressure, which is an indicator that there's a significant unloading effect on the ventricle. And in fact, the antegrade flow through the device is not, or through the ventricle, is not coming from the amount of work the heart is doing itself, but rather through the device. The third part of the equation relates to coronary perfusion, and as you can see, coronary perfusion can be measured as a transmyocardial perfusion gradient with mean arterial pressure and LV end diastolic pressure. So the end point here of coronary perfusion is actually a summation of the effects on circulatory support and ventricular unloading. And to solve this hemodynamic equation, you have to have a device that can effectively do all 3 components of the hemodynamic support equation. So here's a flow diagram looking at how the Impella design is best suited to solve this hemodynamic support equation. As Seth indicated, the device is placed into the left ventricle with an inflow segment here that then shuttles blood through this cannula and then out into the ascending aorta through the aortic root. And so by sitting across the aortic valve, the device can essentially uncouple the ventricle from the aorta. And the first effect of the device is to increase flow. And by increasing flow, this means that there's rotational kinetic energy coming from the impeller that's transferred to the bloodstream. And that energy coming from a battery-powered motor essentially now takes over the amount of work that the heart would otherwise have to do. So you get a significant increase in cardiac power output, which is augmented by the device itself. The second component of the effect of the device is that circulatory support portion of the equation, which is to increase mean arterial pressure. And the third component is to reduce LV end diastolic pressure and LV end diastolic volume. And this combination of a reduction in pressure and volume in the left ventricle is the hallmark of ventricular unloading. The downstream effect of reducing pressure and volume inside the left ventricle is twofold. One, you'll see a reduction in wall tension, which has a significant impact on microvascular resistance and then ultimately augments coronary flow. And number 2, you'll see a reduction in the amount of work that the heart has to do. And this has significant implications because, as you can see, the circuit is integrated. By reducing microvascular resistance, by reducing wall tension, this combination with an increase in mean arterial pressure leads to increased coronary flow. And as a result, you'll have a significant increase in the amount of oxygen being supplied to the myocardium. And unlike other devices, when you actually achieve unloading of the ventricle, you get a significant reduction in oxygen demand. So as a result, you can tackle both supply and demand as it relates to myocardial perfusion, and this potentially could lead to myocardial recovery, especially in the conditions of cardiogenic shock in the setting of AMI or an ischemic substrate. So this next slide indicates the effects of the hemodynamic effects of the Impella device in a patient coming in with cardiogenic shock. And what you're seeing here are simulations using the Harvey application, looking at hemodynamics both at the systemic circulation, so this is mean arterial pressure here in the top curve, and this is LV pressure, or LV diastolic pressure here in the bottom curve. And this particular patient came in with a 75% left main stenosis, had a low ejection fraction, a low cardiac output, and an elevated wedge pressure. And as you can see in the first part of this time continuum here, that within a matter of seconds, this patient is starting to decline and have a significant reduction in mean arterial pressure and an elevation of LV end diastolic pressure. And this is the classic hallmark of cardiogenic shock. When the Impella device is inserted and activated, within a period of seconds, you'll see a significant increase in the mean arterial pressure. And this is shown here, represented by these waveforms. Each bar represents one heartbeat. And this significant increase in mean arterial pressure is accompanied by a narrowing of the pulse pressure, indicating that the ventricle is not doing as much work. The pump is now taking over a significant portion of that work. And so this part of the equation where we look at this increased mean arterial pressure achieves the first part of the hemodynamic equation, which is to provide circulatory support by increasing mean arterial pressure. On the bottom curve, at the same time that the device is activated and mean arterial pressure is increasing, we see a significant reduction in LV filling pressure, and this is that ventricular unloading effect represented in the pressure time domain by a reduction in LV EDP. And then this gradient that you see here, measured before the Impella is activated between mean arterial pressure and LV EDP, represents transmyocardial perfusion. And as you can see with the patient who's coming in cardiogenic shock, this gradient is quite narrow. But once the device is activated and you've uncoupled the ventricle from the systemic circulation, the gradient between the mean arterial pressure and the LV EDP starts to become very significant. And this again leads to that third part of the equation, which is coronary perfusion. And that's how the Impella device essentially solves the hemodynamic support equation. Now this has been studied in a number of different studies. We've all seen it clinically in the procedure rooms. But the ISAR shock trial, this was a randomized controlled trial, a very small study, which primarily looked at hemodynamic effects of the devices, comparing the Impella 2.5 versus intra-aortic balloon pump. So 13 patients in each arm, and the primary take-home message was that there was a superior increase in cardiac index with simultaneous ventricular unloading with the Impella device. And this is shown here in these graphs, showing that basically in patients before support was activated, a cardiac index of 1.7 could be seen to increase to 2.2 while on support. And this is in distinction to the intra-aortic balloon pump, which had an increase from 1.7 to about 1.84 with the balloon pump being activated. Another important distinction between the Impella and the balloon pump technologies is that with the Impella, as we described, that rotational kinetic energy now being transferred to the bloodstream takes over the work of the heart. So when you take away the amount of work that the pump is doing versus the amount of work that the heart is doing, there's a significant reduction in the amount of work or burden on the native ventricle, and the Impella device is now taking over a lot of that work. And that's in distinction to the balloon pump, which requires native pulsation to remain intact for counterpulsation to work. Another hemodynamic metric that's come out over the past few years is the cardiac power output. And this classic slide now from Finke and Hockman looked at the shock trial and essentially calculated cardiac power output as a product of mean arterial pressure and cardiac output. And this slide essentially shows that as you increase cardiac power output, whether you're increasing mean arterial pressure or cardiac output itself, you start to see a significant reduction in in-hospital mortality. And this, of course, now leads to a translation of what we might be seeing in the clinical arena, where before you put in a support device, you would see a certain cardiac output of 0.5 in the setting of cardiogenic shock. And then with activation of the Impella device, there's a doubling of that cardiac power output on support. And as a result, you can infer that there's a significant potential reduction in mortality once you increase cardiac power output. And this, of course, comes from our colleague Bill O'Neill, who's sitting right next to me. And this is really important data that you can see for cardiac power output and how it may relate to an improvement in mortality in cardiogenic shock with the use of the Impella device. The next slide here also comes from Bill's study looking at the CVAD registry, and you can see other hemodynamic metrics that we as clinicians would be looking at. And the first one here on the top left shows mean arterial pressure increasing, and this is that circulatory support portion of the equation. The reduction in pulmonary capillary wedge pressure is significant once the Impella is activated, and that's that ventricular unloading effect. And then the combination of the two lead to an augmentation of cardiac index, as we explained, which comes from being on support and the device taking over native ventricular function. This next slide represents an interesting study which I think is very unique because it takes us actually to give us a visualization of systemic microcirculatory effects of the Impella device. And this is using dark field imaging to look at sublingual microcirculation. And you can actually visualize the effect of the device or the effect of increasing mean arterial pressure with the Impella device. And what you can see here in this top panel is that this is the sublingual microcirculation with the Impella off in a patient who comes in cardiogenic shock with an anterior ST elevation MI. And when the device is activated, you start to see a significant augmentation of flow through the microcirculation. So it's one of the most graphic images showing the effect of the Impella device on end organ perfusion, looking at microcirculation in real time. This next slide pulls together a lot of the effects that you were seeing with the mean arterial pressure increasing and a reduction in LV end diastolic pressure. And as a result, this was a nice study from Remelink and colleagues looking at coronary flow velocity with activation of the Impella device during active ischemia or during a period when autoregulation is uncoupled, for example, with injection of adenosine. And what you can see is a significant increase in coronary flow with the Impella device activated. This also is coupled with another study, a case report that essentially looked at one of the few studies looking at active myocardial perfusion in the setting of an Impella device. And what you can see here is an ischemic zone in the heart that when the Impella is off, and then when the Impella device is activated, you can see now a significant increase in global myocardial perfusion simply by unloading the left ventricle without actually doing an intervention on this particular patient. So the key take-home points is that there's now a new FDA-indicated therapy for acute MI cardiogenic shock that allows for new approaches to treatment, that hemodynamic stability for coronary and end organ perfusion is critical in the setting of cardiogenic shock, and that hemodynamic support with the Impella addresses the three main components of the hemodynamic support equation, which are circulatory support, ventricular unloading, and the net effect on increasing or augmenting coronary perfusion. And unloading of the left ventricle reduces microvascular resistance and may promote myocardial recovery, which is an exciting time for all of us in the field.
Navin, thank you for that really great review of the physiology and hemodynamics related to cardiogenic shock and to the Impella support and the Impella device, and explaining it for us on the panel as well as our audience. One of the management issues that this new technology really calls on us is to think about is to be more serious about hemodynamic evaluation and management. 30 years ago, almost every patient in the intensive care unit had a right heart cath. Over the last decade, that percentage has dramatically fallen, and I think many interventional cardiologists often do not rely on a right heart catheterization for evaluation or for subsequent treatment. Jeff, you said that sometimes a right heart catheterization is used even for regulatory reasons just to identify shock. Share with me your recommendations for what we should be telling our audience to consider right heart cath use before Impella support, after Impella support, and then subsequently.
Well, it's very hard for me to even figure out how to treat these patients effectively without knowing comprehensive hemodynamics. I mean, in New York, we're sort of pushed into it anyway because of the way patients are evaluated for shock includes cardiac index. So getting that it sort of forces the hand of the interventionalist for self-protection. But I think it's more of a clinical decision. It's very hard to understand the volume status of these people, the state of the right ventricle, in terms of how to optimize hemodynamics, and more importantly, the effectiveness of your therapy without it. I think the problem the problem with the right heart caths and the way it sort of got its sort of bad rap in the literature is because people didn't know how to use it properly. It didn't really understand how to integrate it with calculations of systemic vascular resistance and biventricular function. So I think it's essential for this management, and there are very few patients that will manage without it in cardiogenic shock.
Yeah, I think those are really important points. I think there are certain patients who, if you have a patient who's hypotensive, who's coming in with AMI, you might be able to skip the right heart cath up front because you know that this patient's critically ill. Your clinical exam, your poor man's swan, as we like to call it, low urine output, cold clammy extremities, and hypotensive in the setting of ST elevation MI really tells you this patient's not doing well. And so I think there you can simply go on support, stabilize the hemodynamics. You can even do the reperfusion at that point, the primary reperfusion, and then you can put in the PA catheter. But the PA catheter has to go in at some point. And that's what's going to allow you to figure out where you are in the continuum of your level of support and then also your weaning parameters. But I do think that, if you're not sure, if you have a patient who's in that impending shock category where the blood pressure is about 100 with a narrow pulse pressure, 100 over 80, is very different from 120 over 80. Those types of patients, I think a PA catheter can help. And in some cases, what we've done is we've just put the PA catheter into the right atrium. And in most cases, the right atrial sat will give you an estimate, assuming no shunt, no intracardiac shunt, to the PA sat. And if I've got a right atrial sat of 30, or I've got a right atrial sat of 90 in the setting of acute MI, both of those are very bad numbers, which are very concerning. And you didn't have to do the full right heart cath. You can actually just calculate the output and index from there. And if you've got those deranged numbers, you can at least then either complete the PA catheterization procedure and then move on, or you can document that you've calculated a cardiac index using the RA sat, even though your blood pressure was 100. And I think those impending shock cases are the gray zone where a PA catheter will make a definitive decision. But if they're hypotensive, sometimes you can skip the PA cath, put it in at the end of the procedure. But either way, that hemodynamic monitoring has to be a part of your approach.
No, I totally agree. I think the mixed venous return saturation is kind of an incredibly important prognosticator. You can start with the mixed venous of 40, and then it goes up to 50, 60. You know you're headed in the right direction. And alternatively, you start with a mixed venous of 75, 80, then it's like, well, is this really truly myocardial shock? Because it seems as though the mixed venous return is that you actually are perfusing end organs. So it really helps early on, and during the flow, day 2, day 3, seeing a continuous improvement is a really good prognostic index that you're going to be able to recover those patients.
So a universal and solid recommendation for right heart catheterization in all these patients.
If I could just make a comment, one of the barriers that I see going forward is that I think we're kind of swaying people away from this door to balloon mania, which doesn't have to, it doesn't matter in shock. It doesn't even count. And I think now door to unload is really good, what we're all talking about. But the other thing is that now everybody's going manic about using radial approach. And in the non-shock patients, doing radial angioplasty does look like it decreases mortality. But that sort of flies straight in the face of shock because you can't put an Impella through the radial artery. And so what I'm concerned about going forward is that fellows coming out of training programs are less and less skilled at getting actual femoral access. And what I would really like to promulgate is use ultrasound-guided femoral access, which the fellows know how to do for getting IJ approaches. In the shock patients, it's actually even better because you can see the artery, you can't feel the pulse because they're in shock, and you can get ready access to the femoral artery safely. But we have to really kind of counter everybody's going to the wrist. Well, you can't support the patients. And so right from the very beginning, if you're thinking, okay, this patient could become unstable, is shocky, then you have to change the approach. You could probably still do the angioplasty from the wrist, but you got to get them on support from the femoral artery as soon as possible.
Yeah, and I think it's interesting because what drove the outcomes in the Matrix study was actually the poor outcomes from the femoral and the high radial use centers. It wasn't that the femorals were that terrible in the other centers.
Talk a little bit about how this collaborative effort works for the patient's care after the cath lab. What kind of strategies are used? I'll start with you, Navin, in terms of collaborating with intensivists, heart failure specialists, about making decisions about how to manage the patient, both in the first 24 to 48 hours and then down the road.
Yeah, so I think there's some really important points here about the concept of the heart team approach. We've heard that term a lot over the past decade or so. It's evolved quite a bit. For valvular therapy. It's now entered the domain of cardiogenic shock, and the members of the heart team here are a little bit different than, for example, with the valve approach for the valve team. Here you're bringing in now a team of critical care intensivists who are primarily designed to treat patients after reperfusion therapy has been provided while they're on circulatory support. So at Tufts, part of our team is actually the intensive care folks, the critical care nurses in the environment. And what they're looking for are not only how to manage the pump in the post-procedural time period, but also they're looking at all of the aspects of the patient in terms of getting myocardial recovery and getting better end organ perfusion. If we start to see, for example, that a patient is sliding in the wrong direction, it really brings us back to looking at how the pump is optimized in terms of its function, and we focus on that aspect of it. So that requires a lot of training for the shock team specifically designed to manage these patients in the post-procedural setting. I think, as Bill and Jeff have also alluded to, it's not only the upfront exam, but it's also what happens afterwards. The post-procedural hemodynamic assessment, the clinical assessment, continues for at least about 48 to 72 hours after reperfusion and AMI shock, and that requires a team effort involving the intensivists.
So, Bill, if you could give us a few comments on when a patient is not thriving after a PCI with initial Impella support, perhaps an Impella CP was placed, what kind of strategies are recommended for consideration of escalation and other recommendations?
Yeah, I think that's a really critical point, and what you really have to start thinking is, what is the end point? Okay, right from the beginning, is there a salvage pathway? So if you have an 85-year-old patient that is a little demented, that comes in with renal dysfunction, frank renal failure, it's really unlikely that patient is going to recover if they don't recover within the first 2 or 3 days. So I think that the support strategy really should be at about day 3, you have to start looking for the exit sign. All right. So if they're not, if they haven't improved by day 3, then it's unlikely that myocardium is going to recover. And so at that point, you really have to discussion with the patient, with the family, and with the shock team, because the shock team is sort of involved right from the early point, and they're saying, okay, are we going to have to gear up to do a surgical VAD if we can't wean them? So getting the shock team involved early is very important, but I think day 3 is very critical. We looked at our own experience at Beaumont in cardiogenic shock and the survivors, and within 12 hours, the survivors got out of shock, meaning that their blood pressure came up and they're off inotropes. So I think that the sooner the heart starts to recover, the sooner the blood pressure goes up and the inotrope requirement goes down, the more likely they are to recover. But by day 3, you're not really going to see any of the stunning that occurs in the acute phase get any better. And so that's really where I think a decision has to be made. And I just want to take a step backwards to remind people what happened in the pre-reperfusion era. When a patient came into any major hospital in the United States in the early 80s, there was a 90% mortality for cardiogenic shock. It was really the most lethal disease that we treated. Now, we've had dramatic improvements with reperfusion therapy, but we still have a plateau at about a 50% survival. And very little has changed since the early angioplasty data. If you look at the 90s and even in the first decade of this century, there really hasn't been much of an improvement. So we've kind of plateaued. And now with the availability of very rapid, easy to deploy mechanical circulatory support, I think we are on a threshold of a major, huge sea change in mortality for this disease. So I'm really delighted to be here and I'd like to kind of talk over the guidelines with you. We talk about cardiogenic shock as a downhill spiral, and the sine qua non is a reduction in systolic and diastolic pressure to the point where myocardial perfusion and systemic perfusion is decreased. So the patients come in, as soon as they go into shock, their LV and diastolic pressure becomes markedly elevated. They go into pulmonary congestion, pulmonary edema, but equally importantly, the stroke volume drops. There's a decrease in systemic constriction and a marked reduction in blood pressure, causing a decrease in coronary perfusion. And Navin has elegantly reviewed the hemodynamic sequelae. The thing that I want to really kind of, again, emphasize, in 1957, there was an article on a drug called levolturnol, which was the predicate for norepinephrine. And they saw that patients coming into an emergency room that were placed on levolturnol had a marked increase in mortality. And we thought, well, they were just sicker, but I think that's really not the case. I think what's happening is that we have to have this compensatory vasoconstriction to try to keep the body alive. We increase that by providing profound myocardial systemic vasopressors, and then you end up with a systemic severe vasoconstriction, which ultimately results in irreversible tissue hypoperfusion and then death. And we've got to break that cycle earlier, because if you get to this point, then the shock basically is refractory. So where are we to prevent this downhill spiral? And I think that really we have to come up with earlier threshold for concerns. When the patient's blood pressure is in the 50s and 60s, I think that's way too late. I think we have to try to catch some of these patients in the earlier phases. The two things that we have to look at is hypotension and peripheral hypoperfusion. Okay, you can do the peripheral hypoperfusion just by examining the patient and see if they're profoundly vasoconstricted. But a very good surrogate for that is a serum lactate level. So if the patient comes in sort of hypotensive on pressors with an elevated lactate, and then sort of starting the use of a requirement of inotropes. I think this is really where we have to hop on these patients to try to intervene on them to prevent this irreversible shock. On the other hand, when the patients come in with severe anoxic brain injury, they've had out-of-hospital cardiac arrest for unknown duration, and there's a marked increase in lactic acidosis with refractory metabolic acidosis, I think at this point the patients are probably in irreversible shock. So we have to really kind of understand what we're doing, and there is sort of a point of no return in some of these patients. So understanding this, I think, is essential. But the sweet spot is really when the patients still are recoverable, where the shock is early, but there has not been refractory tissue hypoperfusion. And in these patients, I think we can abruptly terminate the cycle of shock. So we've looked now in the United States at the CVAD registry in over 2,000 patients that have been treated prospectively for use of high risk, for use of left ventricular assist device with Impella. Half of these patients have high risk angioplasty, and then the other half have cardiogenic shock. So there have been 1,000 patients that have been treated in the registry. You can see that in these shock patients, about 70% of the patients were STEMI, and then many of those patients had shock on admission. These are the patients that are primarily coming in with acute myocardiogenic shock. Some patients do develop shock in the hospital, but the majority are coming in. Again, a very large number of these patients have had out-of-hospital cardiac arrest. Many of the patients have failed balloon pump. And so then people have staged, try to put a balloon pump in, doesn't work. I think we're going to eliminate this in the equation now with the data from Europe and with the European guidelines. I think the use of balloon pumps is really going to be relegated to historical trash bin. In patients with cardiogenic shock that are greater than 12 hours, about a third. So 2/3 of the patients basically are coming in with acute MI shock in the relatively early phase of their disease. If we take a look at the Kaplan-Meier curve, again, in the patients that had Impella used before the angioplasty was performed, there's a significant increase in survival compared to those patients who had been treated. And these patients basically are being treated later on. People have tried balloon pumps, they failed, and they switched to Impella. And I think we just have to get rid of this area right here. We have to really go to a very safe, effective, proven therapy in order to significantly increase survival. The consensus guideline now states from 2015 from SCI, ACC, and the Heart Failure Society that for cardiogenic shock, a support device should be inserted as soon as possible, particularly if attempts at fluid resuscitation and pharmacologic support fail. So again, I really want to emphasize this. If the patients are going into shock, the earlier you can get them treated, the earlier you can get them supported, the better the outcome. And I think we're going to be talking about not door to balloon time, but door to support time. I think that's where the paradigm is going to have to shift in order to improve survival. Now, these are the outcomes by the strategy. So these are the patients then, they weren't supported before angioplasty, they come in shock, and then they have the Impella in place afterwards. These are the patients that had a trial of balloon pump and failed, and then had the Impella put in. And these are the patients that had the Impella put in first, then angioplasty, and then continued Impella. And you can see there's a significant increase in survival in the patients in whom this strategy is applied first. So I think this is really probably the most important message I have for today, is that if you think you need Impella, use it. The quicker the better. The quicker the patients are supported, the more likely they're going to have recovery, not only of the myocardium, but also preventing severe tissue hypoperfusion and refractory systemic shock. So again, a really important point is vasopressors. And again, I want everybody to remember that tongue picture that Navin showed. When patients are put on vasopressors, the entire tissue circulation constricts, and you have profound tissue hypoperfusion of the end organs and of other parts of the body. So in addition to that, the myocardium, the coronary arteries, have alpha and beta receptors. If you're starting to use high dose of inotropes, you're primarily causing a marked increase in alpha constriction, which causes myocardial hypoperfusion. So the higher the dose of alpha agonists, the less you can get myocardial perfusion. So ideally, the sooner you can get the patients off the vasopressors, the more you're going to improve coronary perfusion. And so this is really important. You can see that 75% of the patients that were in the ISR shock had removal of inotropes after they'd had Impella placed in. And again, even with a 5.0 device, you can see there's a significant reduction in the need for vasopressor support. So all we had were vasopressors. That was the only thing that we could do to support systemic blood pressure. Now that we've got mechanical circulatory support, the quicker we can wean the patients off of vasopressors, the more you're going to get systemic hypoperfusion and myocardial hyperperfusion to try to improve myocardial function. So these are the patients then looking at data from STRETCH in the contemporary era, what's happened to outcomes. And you can see that in the patients in the post-percutaneous ventricular assist device era, there's been a significant decrease in mortality in the shock patients at their institution. Overall, in a very large community experience with about 1,000 patients, again, you can see that the percutaneous assist device is actually associated with a significant decrease in mortality compared to the patients that are treated with the surgical mechanical circulatory support. This, I think, is kind of impractical, except in many high-volume heart failure transplant institutions. You know, you're just not going to have patients have surgical VADs put in. And I think this is really effectively what we have for the large number of patients coming into all of our hospitals in the United States. The thing that's really critical about the use of these devices is that when you can see the patients coming into shock, 90% of the patients that survived had a bridge to recovery, meaning that they didn't need any further circulatory assist. There were about 10% of the patients that went on to elevate it to surgical VADs, possibly a heart transplant. But I think the important point is that you can recover myocardium if you can get these patients supported early on. So in terms of cost effectiveness, obviously in our current health payer environment, this is really, really important. And what we're finding is that the patients that get really good mechanical circulatory support in a variety of settings have a reduction in length of stay. If you look at the elective and the PROTECT II population, a significant reduction in length of stay, a decrease in repeat hospitalizations, and a very, very cost-effective use of this device. And for this reason, Medicare and CMS have agreed to pay for this. It's a very good thing for the hospital. It's a very good thing for society. In addition, in the emergency setting, these patients really have a marked decrease in length of stay because you're bridging them to recovery as opposed to keeping them on a device for a long time and then ultimately having them expire a very costly and morbid death. So this is really going to be very, very beneficial in this emergency setting. So the key points is that I believe that you have to intervene on these patients early. By the time they're in refractory shock, it doesn't matter what kind of heart support you're going to have, the patients are going to die. You got to get to them early, you got to support them early. If you can stabilize the hemodynamics prior to angioplasty, then you are going to improve survival. And I think the paradigm will need to shift for this concept of door to unload, which I think Navin is really pushing. I think that's going to be really, really important. And then I think we're going to have to identify a criteria for hemodynamic support so that each institution can kind of decide what device to use and when to use it. But basically, the simple message is the sooner the better. Door to support time is going to become a really important quality paradigm in the future for management of these patients.
Bill, fantastic. Thank you very much for that really great review, making a really compelling argument for early use of hemodynamic support with Impella. So you cited the 2015 guidelines recommending use of mechanical circulatory support if other strategies fail. And this really is the area that I'd like to press all of you on. All of you are leaders at your hospitals, teaching fellows and others about interventional cardiology approaches. What is that failure? What is a way for an interventional cardiologist managing a patient with STEMI at night, primary PCI? I'll start with you, Jeff. At what point is it appropriate when a patient comes to the cath lab from the emergency room to start with Impella? What would you advise fellows and other colleagues that Impella first is definitely recommended in this subset of patients?
Well, I think there are two major ones. First of all, and this is to emphasize the vasopressor inotrope argument, they're doing exactly the wrong things. And when we look at this equation, so you think of physiologically, when you're starting to even escalate vasopressors and inotropes, that's we're focusing on blood pressure. What you should be focusing on is the heart. We're not increasing perfusion, we're whipping the heart, we're decreasing coronary flow. My goal actually is to get the patient off them, because I think of them as temporizing maneuvers that are actually toxins right now in this circumstance. So that's, at that juncture, When you see these escalating beyond the minimal doses, I think it's time in the suitable patient to actually place it. The other part of it is actually for the intervention. There's a tendency for people to say, look, let's get the artery open, we'll see what we can get away with. Well, these patients are very unpredictable. You get no flow, you get thrombotic occlusion of a contralateral artery. You need further intervention in other vessels. You need that patient stabilized for you to work optimally on that patient. And I think that's the real message that Bill's data has given us, is to get it in first. You have a physiologic situation that is suitable for the heart, and it gives you time to really operate effectively on the patient. So that's why I believe the sooner the better. Anything more than minimal pressors, I think it's time in this situation to really intervene with the support. I mean, the problem is the heart isn't pumping. Let's pump the heart.
So thank you, Jeff. So basically, I think if I could shorten that to say escalating pressor doses, vasopressors, inotropes are really an indication for Impella use.
Yes.
Navin, do you have additional recommendations for?
Yeah, I think Jeff summarized it very nicely. I think there's sort of the pre-cath lab considerations and then the intra-procedural considerations. I'll simply say that when I trained, one of the major mantras that we were taught as interventional fellows is that the enemy of good is better. And that if you're trying to push things too much in the cath lab, especially during the coronary intervention, that sometimes you might actually create more problems if you're trying to put in more stents, trying to do a more complete job at revascularizing somebody. And that mantra now has really changed, because with the new platform of acute circulatory support technologies, we can actually do better. And in fact, you can do it safely. So I think that in the setting of cardiogenic shock, especially in AMI, that's a particular importance, because part of the therapy that we're providing is not just reperfusion, but it's how you provide that reperfusion. And as we've talked about previously, I think that with the support technology in place, you can provide a more comprehensive revascularization, which may be something as simple as we've talked about of putting in microvascular vasodilators, which you couldn't do that if a patient's hypotensive. But if you have that mean arterial pressure elevated, the LVEDP is low, you've got the pump taking over the work of the heart, you can now actually reduce that microvascular thrombus burden and the no reflow phenomenon just by being more aggressive with adjunct pharmacology, and then also with your technical aspects of the intervention. And I think that intraprocedural component of it is critical when we're trying to figure out how to tackle somebody coming in the lab in cardiogenic shock with a high thrombus burden or with critical anatomy that we have to deal with.
Okay, well, great. So I think if I could shorten and summarize yours, it's the greatest value is really the ability to do a complete revascularization and to really stabilize the patient to be able to thoroughly treat them with both more advanced pharmacotherapies and mechanical therapies. By that'd be great. Bill, how about early treatment? What do you counsel at your hospital?
I think that first thing is a physical exam, okay, by somebody that kind of knows what they're doing. And what I'm looking at is for signs of peripheral hypoperfusion. So the extremities are cold and clammy, so the cardiac output is down, as opposed to other forms of shock, right? I mean, a septic shock, something else that's non-cardiac. So that's first, signs of peripheral hypoperfusion, and then need for pressors. I think at that point, if the patient's, okay, so they started with a pressure 70, you get them a little dopamine, their pressure's up, they're sick. And I think those patients need to be supported. There's a conundrum that I never really understood and until today, really. In patients with, when we did angioplasty and acute MI shock, TIMI 3 flow rates are sort of 75%. And in non-AMI shock patients, the flow rates are 95%. So why the delta? And I think the delta is because the patients in shock are being supported by high doses of vasopressors. And so you're actually getting coronary mycoconstriction and inability to have adequate TIMI 3 flow. So again, I would totally agree with Jeff. The sooner you can get the patients off the inotropes, the more likely you are going to have adequate myocardial perfusion and then myocardial recovery.
So you've all made a really compelling argument for early use of Impella in STEMI associated with cardiogenic shock. The initial decision-making about which mechanical circulatory support device to use in the cath lab in a patient with STEMI, you've all made a really compelling arguments that the balloon pump is really ineffective and may even be harmful. Which device of the Impella platform that has now been approved do you generally start with? What different options might you take on? And Bill, I know you have some novel approaches. Maybe you can start.
Well, you know, again, bigger is better. We thought that for always in interventional cardiology. So we really have not used the 2.5 device. I think there's really no downside with using the CP. The sheath size is about the same. You get a significant increase in forward cardiac output. And so that's really kind of our transfemoral standby. In patients who are in more extreme shock and are going to need more support, we are using a transcaval access femoral vein to aorta, and then putting in the 5.0 Impella, which you can do in an emergency setting, and we have done. And so sort of escalating to that is still, I think, in the early learning stages. We think that it's going to be a very good way of supporting patients in extreme shock. But right now I think the standby is basically the CP.
Navin, do you have comments about which?
Yeah, so I agree with Bill. I mean, I think at our institution we're primarily using the CP. It provides more flow, more unloading, just by the engineering advances in the technology. I think the other unique aspect of, in addition to providing left-sided support, is the fact that a lot of these patients who come in AMI shock have some degree of RV involvement. And so in particular, over the past year or so, with the approval of the RP, we've now been actually identifying these patients early on. And I think part of the reason why cardiogenic shock still has a high mortality rate is that we have a very univentricular approach to cardiogenic shock. We see a left main or an LAD that's involved. We assume it's just the left ventricle. But all those septal perforators are making the interventricular septum ischemic. The volume overload condition is now driving the RV into worsening dysfunction. And what we're seeing is that actually probably close to about half of these patients who come in AMI shock have some degree of RV dysfunction. And so putting in a univentricular support strategy will help in many of those cases. But when the RV is severely dysfunctional, we now have to look and see what can we offer the right side. And so this combination of a CP with an RP really has been a very nice advance at our institution and at many institutions across the United States to use what we call the bipella configuration and take over all aspects of the heart in terms of right ventricular and left ventricular support, getting us better end organ perfusion. And I think that's an important metric going forward that we'll have to look at, is how to identify RV failure in the setting of cardiogenic shock and how to escalate therapy, not only CP to 5.0, but then also when to put in the RP and support both sides of the heart.
Jeff, we have this new technology, and we've hear some very compelling arguments for early use. You have a large referral practice here in New York. How can we encourage hospitals that may not have access to this technology to call earlier and to get patients in? And what would you think would be a recommendation for all of your hospitals, our large tertiary academic medical centers, thinking about a spoke and hub strategy for availability for cardiogenic shock advanced therapies?
Yeah, I think that's a very important question. And certainly at our institution, we're becoming a broad-based regional network. It's happening in many situations, and we are just beginning to touch on this subject in terms of devising protocols. I think the key is not to, the inertia is the problem. You put someone on a little pressor, they're a little wobbly. I think, you know, the tendency is to keep them, you've done your MI angioplasty even, you've kept them where you keep them where they are escalating your therapy, and they're gradually deteriorating till urine output decreases. Manifest perfusion is, malperfusion is there. I think you've got to back that up. You've got to educate your system to really, when you see any sign of trouble, getting it into the center. There are also opportunities, as I was mentioning, you know, that half of these patients are now in smaller hospitals. We have to reduce the barriers for using this technology. With a well-trained staff, a CCU staff, a cath lab staff, putting one of these in, I'm sure in your lab too, it's really a couple of minutes more than a balloon pump. With the rapid prep, with comfortable nursing, and I think we also have to migrate the technology out further into the community, conjoined with the major centers. But I'll say one thing about the biventricular stuff. I mean, the beauty of having these percutaneous right ventricular options is the option before was a BiVAD. And in Columbia, we're very aggressive. We have a team. Our VAD team is the surgeons. We have a cardiology. You know, we have a heart failure specialist. We have now a joint fellow. And every VAD is rounded on every day, and every out, migration out and pathway is actually decided on very early. There are some people who obviously are either going to make it or not on this device, but all the other pathways are there. But the BiVAD was always, the surgeons would do it, but it's always a big deal. So the fact now that I think that surgeons are the happiest people in the world now that we have several biventricular support options that don't really entail cracking the chest.
So Jeff, you said that putting in the Impella is actually with a skilled staff and a skilled physician. It takes very little time, just a minute or two more than intra-aortic balloon pumps, I think you said. One of the complexities in cardiogenic shock management is what to do after the cath lab. For many physicians who have acquired the skill set using Impella and protected PCI, the device is taken out in the cath lab. What are strategies that are used for weaning? Most patients with shock are going to leave the lab with this support device. What metrics or what kind of strategies are used to decide about lowering and weaning the device or other decision making?
Well, I think first of all, a rule of thumb is we let them ride it out for at least 48 hours. We want the recovery aspect, I think, is quite important. And then obviously you can tell where they're going. If they're migrating into less favorable hemodynamics, then obviously then the discussion isn't weaning. The discussion is escalation of therapy in terms of larger devices, more durable devices, or even transplant. And that's done in conjunction, obviously, with the VAD team, which includes the heart failure specialists as well. If they are doing well, if your end organ perfusion is doing well, your PaO2s have adequate cardiac output, the patient's mentating well, you're not in pulmonary edema, then we will do a gradual wean, generally over 8 to 12 hours, watching all those parameters literally on an hourly basis. And it's very important to have the nursing staff. It's also very important to have trained nursing staff and fellows just to understand the optimization of this device and the potential for migration as well. And the good news is these devices are much more stable. I think with echo guidance also you can really optimize these at the bedside very simply. All you need is a color flow really, and you can understand it. But I think it's a gradual process, but I think you rapidly know where they're headed as you wean them down. If you cannot wean them down, then it's a matter of escalating therapy. But I think I think if they're recovered, you can see it pretty rapidly. The wean could be actually pretty significantly enhanced as you see the blood pressure stability and the cardiac output stabilize as you decrease the power of the motor.
Okay, great. Navin, any comments with regard to weaning decision making?
Yeah, so I think it's a critical point that once we put one of these devices in and Impella goes into a patient with cardiogenic shock, even if it's post-MI, one of the first calls that we'll make when we're in the critical care unit is to our advanced heart failure team. So we notify the heart failure physicians that there's a patient who's on mechanical circulatory support, who's post-MI, who's been revascularized, for example. And the primary reason we do that is we want to start the ball rolling early in anticipation of the inability to wean and the need to escalate therapy to a surgical VAD, as Jeff indicated. And that process can take a period of about 48 to 72 hours to make that multidisciplinary discussion. And so the earlier you can activate your heart failure component of the team, the better. The next thing that we look at in terms of a nuts and bolts aspect at the bedside is every morning we do a turn down on the Impella device. And the primary reason we do that is we want to see what is the native ventricular output. And there are a couple ways to measure that. And one of the quickest ways to do that, one-to-one with dialing down the P level, is to simply look at the aortic waveform or the radial arterial waveform. And what you'll see is that is a return of pulsatility and a return of that pulse pressure. And if I have a patient who's ejecting at 120/80 on their arterial waveform with the Impella at P8, then I know, for example, that at that point the native ventricle is doing quite well and is actually generating a pulse flow through the device. And when we turn the P level down, if I don't see that return of pulsatility, if I see that someone has a narrow pulse pressure on the support at P8 or at P3, it means that the ventricle hasn't really quite recovered yet. So the combination of looking at the hemodynamics, looking at the mixed venous saturation, as Jeff indicated, also looking at an echocardiogram when we're doing those turn downs to see if the LV is doing okay and the RV is tolerating the hemodynamic support and the cardiogenic shock scenario, are things that should be done on daily rounds in the morning, and that early activation of the heart failure team is critical because that starts to build the pathway for the possibility of not being able to wean and the need to escalate therapy to a more durable support device.
We have our VAD team, every VAD in the hospital, including the PVADs, are rounded on by the team every morning.
Yeah.
And we do that systematically throughout the entire hospital.
Yeah, and I think that's a paradigm shift for interventionalists. You know, as you said, a lot of this occurs in the cath lab, and then once they step out of the cath lab, the interventionalist may not be directly involved there. So if the interventionalist doesn't get involved directly in that aspect of the care, it has to be handed off to a team that knows how to integrate the interventional component with the heart failure component.
The other, there's a few other practical things that we have to kind of consider. So we're talking about acute MI, cardiogenic shock, patients coming emergently to the cath lab, middle of the night, weekends, whatever. You put the Impella in, you support them, you do the angioplasty, you got them out of the cath lab. And so then it's sort of like day one. And day one, you kind of mop up the mess. Did they have a stroke? Are they neurologically intact? Is their liver working? Are they in renal failure or not? And all of those things really kind of accumulate into sort of a survival probability. If they're brain dead, for instance, then you know what are you doing? And or equally important, if that's severe liver dysfunction, liver necrosis, and then the LFTs go up, and so that's really very problematic. If none of that happens, if you've gotten to them quick enough, and they're making urine, creatinine's coming down, no problem with liver functions, you have to look at the extremities because, again, one of the problems could be that they're having hypoperfusion of the leg, and so you have to kind of decide, okay, is the leg okay? And if the leg's okay and their bune and creatinine are okay and they're systemically kind of getting better, then you have more optimism that they're going to survive. I don't think you really need to do very much within the first 24 hours in really recovering them. I think that they will recover, and then probably at day 2 and then at day 3, the strategies about weaning start to become important. But the mop-up phase is very, very important. The first 12 to 24 hours, you'll get an idea of their survival probability. And I think, again, the sooner you can get to the patients, the less likely they're going to have these other complications. What I've seen over the years in management of shock patients is that you can get them out of the cath lab with an artery open and the heart okay, but it's the renal failure, it's the liver necrosis, it's the bowel ischemia, it's the stroke that ends up killing the patient. And so I think we'll get rid of all of those problems if we can get them supported earlier.
Yeah.
So you've all helped outline the path to weaning in a patient that may be doing well over first day. Bill summarized, second day Jeff summarized, day 3 and beyond Navin summarized. Those were a patient who was on the path to recovery. On the other hand, a patient that may not be on the path to recovery, to use Bill's idea of evaluating the patient for the first day for multi-system failure, that's obviously a key predictor of poor outcome. But a patient that may not have multi-system failure, but it has poor cardiac performance, what other strategies are available that you use for management of these patients to support them?
Are you referring to specifically how we start to track and look at escalation of therapy?
Yes.
Or? Yeah, so I think that's, again, where we partner very closely with the advanced heart failure team. And if we've got somebody who's got a primary cardiac failure problem and we don't think that they're recoverable using a percutaneous technology like the Impella platform, then a number of decisions have to be made. And this is really a standard, almost biweekly meeting that occurs with our advanced heart failure transplant team as to whether or not a patient's a VAD candidate, a transplant candidate. It does vary depending on what region of the country you're in. A lot of patients will stay on the Impella and bridge to transplant. Other patients will stay on the Impella and have to be escalated from a CP to a 5.0. When we put in a 5.0, we do it through an axillary cut down. Patients are ambulating, engaged in physical therapy, basically on what would be termed as a non-dischargeable LVAD, basically the equivalent of LV level of support. And then there are patients who require a bridge to a durable VAD, and that's again where we integrate that team to make that decision. So I think that's why, early on in the mop-up phase, I think the sooner you can simply alert the heart failure team let them know that this is what's coming down the pathway, and then you start to, within that first 24, 48-hour period, if you're not seeing the recovery, you know you're going to have to bridge to something else, and that's where that algorithm starts.
But I think for the families also, there are certain people who segregate out very early, certainly the first 24, 48 hours. And I think it's also important to get have expectations for the family and have them understand what direction we have actually possibly going in.
Seth, another common strategy that people think about, and I think is starting to be popularized in Europe, is using ECMO in AMI shock. I think that's absolutely the wrong, stupidest thing to do, because what you're doing is you're trying to get the heart to recover. And ECMO does not cause the heart to recover. The heart dilates. We have data that's at least 15 years old that shows that patients go from frank lactate extraction to lactate myocardial production, ischemia, as soon as they get put on fem-fem bypass. If the patients have severe pulmonary failure, then they might need an external oxygenator. But I think that we have much better strategies right now, and I really strongly argue against using ECMO in acute MI shock.
Any comments about ECMO? Both Bill and Navin made significant comments about the importance of unloading, and Bill, you've now highlighted that the ECMO strategy actually loads the heart. Any strategies around ECMO management, should it be needed, for instance, in the setting of a patient who needs to be oxygenated?
Well, I think, when we have a total crash and burn and frank pulmonary edema where you want end organ perfusion and oxygenation, I mean, there is a place for that. It's not the total answer, but now it's cerebral survival is your first priority here. So, there are situations coming up from the ER that it's the simplest thing to do to stabilize the patient from just the circulatory standpoint. It's not resolving the cardiac problems, and certainly Navin probably has more expertise in this area than I do, but we did at Columbia pioneer the idea of unloading these dilating ventricles, directly with the with the Impella. We started with actually the 2.5, and we find that's a good combination to really optimize it, because there are situations where you just simply can't oxygenate the patient.
I'm not sure our audience understands. Could you review what you mean when you say unloading with Impella and ECMO?
Well, as Bill cites, you have afterloading the heart. If the heart is not ejecting, it compounds the pulmonary edema problem, and of course it also compounds the ischemic problem of the heart. And the idea is if you want to shrink the heart, we'll actually put in either a femoral or an axillary ECMO to actually potentially vent the heart. And there are other vent strategies, but this seems to be with the Impella. With the Impella as the device to actually unload the heart and supplement the actions of the ECMO and avoid the problems that you have with the afterload issues that the ECMO does produce.
Yeah, I think so. All the statements I think I agree with for the most part. I think there is a role for VA ECMO in the management of patients who are critically ill. At our institution, we're primarily using VA ECMO for patients who have oxygenation problems, who need cardiopulmonary equivalent bypass, or where both issues are a priority. We also find that VA ECMO has a role potentially in biventricular shock, and for patients who can't make it to the cath lab because of its peripheral cannulation that can be done without fluoroscopy. I think Bill highlighted the point of this loading effect. So if we go back to that hemodynamic support equation of circulatory support, ventricular support, and coronary perfusion, the primary effect of VA ECMO is to displace blood volume from a large capacitance venous reservoir into the arterial system. And it does so at a high flow rate. So if you take 5-6 liters per minute of venous blood, oxygenate it, and put it into the arterial circulation, which is a non-compliant circulation compared to the venous circulation, all of a sudden you distend or pressurize the arterial tree. And now as a result, your mean arterial pressure comes up, and that solves the circulatory support portion of the hemodynamic equation. But what happens is when that mean arterial pressure comes up, unlike an Impella device where you're increasing the mean by unloading the ventricle, now the ventricle has to work harder to eject against that afterload effect. And so the Impella configuration that was pioneered at Columbia is the idea of combining this ability to oxygenate, displace venous blood into the pressurized arterial system, and then unload the ventricle now with an adjunct, another device next to the ECMO circuit. And that becomes challenging because now what you're proposing is VA ECMO, so femoral cannulation in most cath labs, then an additional femoral cannulation for an Impella device to unload. And so that starts to increase the amount of vascular injury, starts to increase the amount of ischemia to the limbs, which can become a real challenge. So I agree with Bill and with Jeff that in isolation, VA ECMO by itself will not effectively unload the left ventricle. It will increase your blood pressure, which if you're having cardiac arrest or in extreme critical situations, that's a great stabilizing maneuver. But for that 24, 48 hour, 72-hour period, we're talking about stabilizing patients post-revascularization, that's where just ECMO alone in isolation is not enough. The other component to this is, as we talked about with the vascular cannulation, is that now you've got patients who are on bivalirudin, who are on dual antiplatelets, who are on systemic antiplatelet agents in the setting of an AMI. And so those large bore cannulas, to actually achieve the flow rates, they really require about a 24 French venous cannula and anywhere from a 17 up to a 19 arterial cannula with an antegrade perfusion sheath. So it becomes a much more complicated environment when you've got someone in an AMI scenario, especially after primary reperfusion for ECMO. So I agree with Bill that I think it's not the optimal device for patients with AMI shock.
See, I think that one of the misconceptions is a patient comes in acute MI shock, their blood pressure's down, and they're not oxygenating. Okay, well, simplistically it sounds, let's put them on VA ECMO, you'll oxygenate and blood pressure goes up, problem solved. Well, that's really not the problem. The problem is that they're in shock, their LVEDP is markedly elevated, they've got pulmonary congestion. If you can drop the LVEDP, the pulmonary congestion will go away and they'll start to oxygenate. And I think that's really kind of a better way of looking at it. You have to take a look at day 2 or day 3 in terms of the complications that occur. And all of these putting in 3 different large arterial sheaths and 1 big venous sheath, the rate of vascular complications at day 3 starts to skyrocket. And so I think, again, you have to be thoughtful early on what is the best way to support the patients in kind of like the least invasive, least intrusive manner possible. So I'm very much in favor today of starting with Impella. If they have signs of RV dysfunction, going up to right side of support as well. That gives you 1 arterial sheath and 1 venous sheath. And I think that'll really markedly limit the complications that can start happening at day 2 and day 3.
Today's discussion focused largely on the therapies that have existed, primarily balloon pump, inotropic therapy, and vasopressors, and their shortcomings. And a new therapy now, the Impella platform of devices, is available, and we discussed many of the challenges, and really this is a call to action for both physicians individually to develop the skills, as Bill said, make sure that safe and effective femoral access is a skill set, that centers and that even regional healthcare delivery systems are able to integrate the Impella platform of devices into cardiogenic shock care, with the hopes of moving this high mortality rate of around 50% to substantially lower with early identification, early treatment, and a team-based approach to cardiogenic shock. I thank again for joining us for this educational webinar.
So this is an interesting case that I thought I'd present to the group, and I'd love to hear your thoughts about this particular patient who came in with ST elevation MI. And as you can see on the slide, I put in shock in quotation marks because that's part of the issue here, is how you define cardiogenic shock in this particular patient. So this was a 56-year-old gentleman who arrived with new onset chest pain 24 hours prior to coming into the emergency room. He's having persistent 3 out of 10 chest pain, and his initial electrocardiogram shows inferior ST elevation MI of 1 to 2 millimeters. He's tachycardic. His blood pressure is highlighted there for you. It's 110/80, and his respiratory rate is 24, and he's oxygenating well on a face mask. As you can see from the exam, we're looking for certain signs of pulmonary edema. We're looking at his lower extremities, and in particular, What was striking about this patient when I examined him was this evidence of cutis marmorata, or hypoperfusion of his largest organ, which is his skin. And this particular pattern, I think, is very important for us when we start to bring these patients into the cath lab as a potential harbinger of badness that's coming down the pike before we start to revascularize someone in a STEMI. We then performed an echocardiogram as we're getting the patient evaluated up to the cath lab, and we see an ejection fraction of 35%, infra-posterior akinesis. There's no structural complication from the MI at this stage, no VSD, no MR, and the RV is normal, importantly, as well as no pericardial effusion. So I think one of the questions that comes up is whether or not this is cardiogenic shock. And I think maybe I'll just ask the group here as to whether or not you think this is cardiogenic shock, just based on this exam and how you might proceed forward in terms of the management of this patient.
Well, they've got profound peripheral vasoconstriction, and I think looking at the skin and also just feeling this cool temperature, I think that, to me, there's a spectrum of shock, and this is kind of early or pre-shock. You got the patient very early, but they're starting to show signs of tissue hypoperfusion.
And this is where I think a PA-SAT's invaluable. I mean, that would clarify what the real status of the patient, I think.
Yeah, I think it's a really important point. As we go by our NCDR metrics and we look at, when can we check the box of cardiogenic shock? Right now, you can't really check the box. The blood pressure is over 90. You do have a narrow pulse pressure, 110/80. And your exam and your clinical intuition is telling you that this probably is cardiogenic shock, but you still have to document it. So that's where we then took this patient to the cath lab, and we then performed a coronary angiogram, which I think is a very important primary step in evaluating these AMI shock patients. And what you'll see here on the angiogram on the far left is you'll see that there's a thrombotic occlusion of the left circumflex with TIMI-1 flow through a very large circumflex system. And on the LAD here in the middle panel, you'll see that there's a large LAD, but it's diffusely diseased. There's some mid-segment disease. There's an apical segment that's virtually occluded. And on the right is a non-dominant right with very small collaterals going to this apical segment of the LAD. So multivessel disease and a left dominant system involving the LAD and the circumflex. The circumflex is the culprit vessel that we would target. So we said that, in our cath lab discussion, our next step was whether we should just quickly open up this left circumflex. Jeff mentioned doing a right heart cath. Should we think about going on support right now in this particular patient? By our clinical intuition, we think that this patient is headed in the wrong direction. If you go back to the slide we had showed about impending hemodynamic compromise with a reducing mean arterial pressure as this patient slides deeper into cardiogenic shock. So our approach here was, as Jeff indicated, was to get some hemodynamic data. And this really adds only about a couple minutes for us to do this, to put in a PA catheter while we've got radial access or femoral access on the patient while we're getting set up to do a PCI. And to us, this was a very important aspect of this case. So the initial right heart catheterization showed an RA pressure of 12, so not normal, a wedge pressure of 24, cardiac index of 1.5, and a PA-SAT of 43% with an SVR of 2,400. So really a great example of initial hemodynamics and impending shock. So now that we've got the right heart cath data, we can check off the shock metric. We've confirmed that we're in cardiogenic shock, and now all of a sudden the priorities change in terms of how we manage this acute MI patient, where the priority in the majority of AMI patients is to reperfuse as quickly as possible. Now my priority shifts to taking care of the hemodynamic embarrassment before we start to reperfuse and potentially cause reperfusion injury.
The other thing is that the patient had very severe multivessel coronary disease. And the paradigm, again, is shifting, and I think that there's more interest in doing interventions of the non-culprit, especially in these large MIs. And PRAMI trial, for instance, showed multivessel angioplasty was associated with an improvement in survival. But if they're hemodynamically tenuous, that even builds for the argument of putting them on support before you do multivessel, multi-culprit intervention.
Yeah.
And also the instinct to sort of go in and open up that thrombus. I mean, these patients have no reserve. This is cardiac index. You could almost do better with CPR. And the point is, if anything goes south, you will be doing CPR on this patient.
Yeah.
And that's why I think putting the Impella in is a very important maneuver in this situation.
Yeah, and so this was a little bit of a shift. The fellows are asking, what our next step is going to be now that we have this data on our hemodynamic console. And so our approach here, was to put in the Impella CP. I think part of this is driven by the fact that we're very comfortable putting in the device. We know it's only going to take a few minutes. The nursing staff in the cath lab doesn't have there's no equivocation about whether or not we should do this or not. Can we do it? So the Impella CP goes in. We're getting actually about 3.4 liters per minute of flow. The RA pressure stayed at 12. The wedge came down to 20, and the cardiac index came up to 2.4. PA sat at 54% as an acute hemodynamic response to inserting the Impella device. So this idea of first unloading the ventricle, stabilizing the hemodynamics was the approach we took here. And what we show here on this figure is probably the most exciting part of this case for me, at least being the primary operator in this case. Is, as you can see on the left, you're looking at the pre-reperfusion angiogram where we had a thrombotic occlusion of this left circumflex with minimal flow through multiple OM branches. And what we did in this case was a little bit different. We put in the Impella device. We're now unloading. The LVDP is low. The mean arterial pressure is up. And now what we did was a thrombectomy, and we injected IC-nipride. And I think the ability here to offer now adjunct vasodilators to improve microvascular flow, to get rid of the no reflow phenomenon, to enhance microvascular perfusion and myocardial perfusion is really afforded by the use of a support device. And so by performing the thrombectomy and the nipride, we've gotten basically TIMI 3 flow throughout this myocardium. We have yet to put in a stent, but we've achieved exactly the primary goals of hemodynamic support with AMI shock, which is to unload, stabilize the circulatory pressure, and then also to enhance myocardial perfusion using adjunct pharmacology.
I think your point about giving intracoronary vasodilators is really crucial. And so you open up the artery, you've got TIMI 2 flow. That's not good enough. And so you really want to try to be aggressive. In our place, we use a lot of nicardipine and some nitroprusside, a lot of adenosine. But all of those are going to drop the blood pressure. So if you got a blood pressure that's tenuous in the 80s, you give them something intracardiac, all of a sudden you're kind of in a pre-arrest situation. So you can be much more aggressive with the intracoronary vasodilators while they're on support.
Yeah, and I think another distinguishing feature of using vasodilators in the setting of an active support device versus a balloon pump is that if you were to give vasodilators in a balloon pump and you start to make the patient hypotensive, the effective counterpulsation starts to go away. And you actually get less effective counterpulsation the more hypotensive you are. But these devices instead are load dependent. And so the Impella device, as you start to reduce afterload, the gradient across the device actually starts to go up and you get better flow with the use of systemic vasodilators. So a little counterintuitive to what you might expect, but that now really starts to put the equation into a much positive light. You can actually be more aggressive with these patients and get more support while you're enhancing microvascular perfusion.
And if you didn't have this, your alternative would be, say, to bolus with phenylephrine, increase
Right.
the afterload to allow you to give that, and that's exactly the wrong direction that you want to go in someone with this type of myocardial compromise.
Yep.
I think the stunning part of the case was the very beginning. Bill started off by highlighting the importance of the physical exam. Here we are talking about very advanced technologies. We're talking about hemodynamics and physiology. Bill highlighted the importance of the exam. You highlighted the skin and the thigh. Jeff has previously talked about just touching the dorsum of the patient's foot. I mean, these very low-tech strategies made a dramatic difference in the management of the patient. And I think that one of the frustrating parts of our specialty many times is the critical need of checking a box, as you highlighted, but here you used very simple, almost skills as a clinician to make the right decision for the patient, and really altered your approach dramatically.
Seth, I think we have to retrain our young trainees because again, you have this railroad track. When I show up with an acute MI STEMI call, I'm there and the patient's on the table, prepped and draped with the radial axis, ready to go. And did someone actually examine the patient? Because that's really crucial. I mean, it sounds stupid, but it's not, because there's like this massive door-to-balloon rush, which is like get out of the way, don't do anything, just get them on the table and get access. And I think we have to step back a little bit, and that's where the senior physicians have to listen to the presentation. Young person, large infarct, well, could this be shock? And then you have to go back to make sure that the first base is covered before you get them prepped and draped.
And what I think is particularly helpful, the echocardiogram, which I think is underutilized. It clarifies so much, whether it's mechanical issues, RV status, LV status, and it really contextualizes everything. And one of the most frustrating things I see is that, you go after the infarct artery, they open it up, and then afterwards they're doing the non-infarct artery. Then maybe they do the VGram, and maybe there's no VGram at all. And you can miss a substantial number of issues by not approaching the patient comprehensively before you actually start your reperfusion.
Great. Well, Navin, thank you for that really wonderful case of Impella-supported PCI in the setting of cardiogenic shock. But the highlight for me was the identification of cardiogenic shock with a physical exam. Thanks for sharing that.
I'd like to present this case. They presented to Columbia, and also I'd like to thank our CHIP fellow, Sanjay Kalra, for helping organize this presentation. This is a young guy who was admitted with a high-risk STEMI, who had an interesting background. He had usual risk factors, had a past history of an ischemic cardiomyopathy. He was on appropriate medications for that, and he was. But the thing is, he presented with 1 year of dyspnea on exertion, worsening over 6 weeks. His EF was 35% at that time. He had multivessel PCI. Remember, this is a year ago. And he was recommended CABG, and this individual just bailed. And he left the hospital AMA. And now he, while he was home, about a month later, he presents with progressive chest pain, worsening dyspnea, EKG changes, and comes to our CCU, and now his EF is 10 with global hypokinesis. He's assessed for viability, which shows that there is viability, and given the fact that surgeon was not an option by the patient's declaration, we had to really think about a percutaneous option. What we have here, as you see, is there's a subtotaled left entry descending artery, high-grade circumflex disease, and a high-grade right coronary artery. At the time of this catheterization, his right atrial pressure was around 10, or he had pulmonary hypertension and a high pulmonary capillary wedge pressure as well. So here we were faced with this issue, and he had, the question is, what's the optimal way to approach this patient? We were committed to a percutaneous revascularization strategy by the patient's declaration, in spite of the 3-vessel disease and neuro-occlusive disease. But the question is, what do we treat first? What's our approach to treatment? Do we use mechanical circulatory support? How do we tackle this multivessel patient? Do we try to do it all at the same sitting? And do we have a strategy in terms of failure modes and bailout plans as well? So our first, we brought him back to the cath lab, and of course, as we've stated multiple times today, our first maneuver, besides putting in the Impella, was really to monitor his hemodynamics. Here we have our right atrial pressure. Our pulmonary artery pressure is actually deteriorated over the course of the decision-making process. His cardiac index is below the shock threshold at 2, on dopamine 10 micrograms per kilogram to support him. We put in the left femoral artery, after angiography, put in an Impella CP, and actually just placing that alone actually got his mean arterial pressure up to 88. So we're already sitting here with a little bit more reserve in this very, very tenuous patient.
So, Jeff, you have a little bit of room for optimism because the EF went from 35 to 10 without an intervening transmural infarction, and so that's number one. Number two, he still can have chest pain, right? So he had, so that to me suggests that there is some myocardial viability. So I would totally agree with your idea to continue rather than hospice in this young guy. I think that intervening will potentially allow for a significant recovery of myocardial function.
And these patients are frequently written off or just sent directly over to the VAD service. And I think we have a renewed appreciation with cases like this, the importance of revascularization, how dramatically the results can change their prognosis. So the plan here was to start with the circ, the direct stent to the circ. We're sort of thinking of what's going to get us into the least trouble first, give us the most reserve, and then if you have to get into the tall weeds, get something done while we have to deal with basically a subtotal LAD. And our feeling is we get the left system fixed. If we are well below our contrast limits and our radiation limits and the patient's tolerating it, then tackle the right coronary artery as well. So that was the sequence of events. The first is a PCI of the circumflex with a direct stent, and here is the final result with an optimal outcome. Now we cross the LAD with a microcatheter and a workhorse wire. We're able to do that with multiple balloons and multiple stents. We're actually able to reperfuse the LAD with TIMI-free flow. At that time, we're well below our contrast and radiation limits, and we decide that complete revascularization is optimal. We have the opportunity on this individual, and we're able to wire the subtotal right coronary artery and place a stent, and here's our final result. Now, the nice thing is now we go looking at weaning after Impella removal. After we weaned, you can see immediately a dramatic increase in the pulmonary artery pressures. This is after the removal of the Impella. His aortic pressure off pressors now has actually stabilized with a mean arterial pressure of 88. We weaned him off pressures. He went to the CCU over 3 days. He had no rise in serum creatinine. Obviously his heart failure improved, which you can see reflected even in the right heart pressures immediately after this, and he was discharged on day 5. The most gratifying aspect of this, the most dramatic aspect, is 8 weeks after follow-up, he's back to his pre-crisis left ventricular ejection fraction of 40, and he didn't even require an ICD, much less a VAD, which looked like his trajectory he was heading into when he was admitted to the hospital.
You know, Jeff, this really validates the message from the PROTECT II trial, because this was a PROTECT patient, and complete revascularization. So the more you revascularize, the better the long-term outcome. And also, we saw gratifying improvements in ventricular function. So I think that you really, when you completely revascularize, you can see a significant improvement in ejection fraction.
I think this is a great case for the heart failure audience out there who primarily take care of these patients. And as you indicated, a lot of these patients with low EF, multivessel disease, are pointed down the road of that advanced heart failure pathway towards VAD or transplant evaluation. But you know, the 3 primary causes of heart failure, advanced heart failure, are hypertension, ischemic disease, and valvular disease. And what's amazing is that in the cath lab, we can pretty readily address ischemia, and we can readily address valvular disease these days. And I think this case really highlights the fact that that upfront viability study is important, primarily to confirm that there's viability. But as Bill indicated, once you're having chest pain and you've got signs of heart failure, it's appropriate to revascularize these patients as completely as possible. And as you can see in your result here, it's a nice example of pointing that patient's trajectory away from the advanced heart failure trajectory towards advanced therapies and more towards recovery. And this is a great example of that.
Yeah, I think besides the hemodynamic stabilization that you get with the Impella, it just gives you that latitude to keep going.
Yeah.
I mean, we're very comfortable, and we also say, well, we've already invested in the Impella, now we have the reserve for the patient built into the Impella, so let's just keep going. And I think also it may also benefit renal function as well, and allow you a little more latitude in the contrast use.
Yeah, I agree.
I think that case for me highlights that many patients who come for acute MI with cardiogenic shock in the setting of STEMI are identified by the interventional cardiologist and may get appropriate procedures with PCI and Impella support. But here's a patient who actually descended over days and maybe even weeks into shock, and by the time he came to the cath lab was clearly in shock by the right heart cath determinations and had really an outstanding outcome. And really this patient will have markedly less recurrent hospitalizations, and as you said, a dramatic reduction in cost. Just the savings of an ICD alone is really dramatic. So Jeff, thanks for sharing that case with us.
Yeah, thank you very much. It's great to be with this group this morning. I want to talk really basically about sort of a proof of concept. Whenever I give lectures about high-risk angioplasty, supported angioplasty, there's always somebody that raises their hands and say, well, I can do bifurcation left main stent from the radial artery, and I don't need any of the support, and I haven't used it in 20 years. And I don't know where they're getting those kinds of patients. So I just want to show you a patient that to me typifies the need for support and exactly what happens. So we've been now putting in catheters, 6 French pigtail catheters from the dual lumen pigtails from the radial artery to monitor while we're doing these interventions. And this is a case example of that. This is a patient that had a total occlusion of the right coronary artery and a complex bifurcation left main that needed rotablator and then bifurcation stenting. So very complex with an occluded. So this is the patient with 3 liters of Impella flow. And then what I did is we put the Impella catheter in, and then we did a very quick balloon inflation of the left main LAD without support. All right, and then this is what happens to the patient. So if we go back here, the blood pressure is sort of, and this is on a scale of 80, and then we go forward, and with the balloon inflation, honestly, inflate, deflate, this is what happens, and the blood pressure drops. I mean, basically, there's no myocardial support. The patients are dying. And to me, it's like this is what happens with these high-risk angioplasties. When you totally cut off all the circulation to the heart, it makes sense that without support. So I don't see how you can do these cases. I mean, you could rush. You could do a quick balloon inflation, deflation, and hope, quick stent. And probably for an osteal left main where you have one stent, it's very simple, up, down, you might be able to get away with it. But for these complex procedures, I just don't see how you can do it. So this is the same patient, and now the patient has the Impella on. We do a balloon inflation, and you can see basically that what happens is that there's basically flat line. There's no forward ejection, but the mean arterial pressure stays at 100. And so you're not getting any peripheral and neurologic hypoperfusion. You're completely supporting the patient. The Impella basically is taking over the complete function of the heart, but allows you with the stability to do IVUS interrogation, rotablator, complex balloon inflations, inflate, deflate. I mean, you can take as long as you need to get an adequate hemodynamic support, and then as soon as the balloon pump, as soon as the angioplasty goes down, then the blood pressure comes back to normal. And we could repeat this. We had to do this multiple times to make sure that we had an adequate, good anatomic result with good apposition of both stents to make sure that there isn't a problem down the road with subacute thrombosis. And then again, you can see instantly, as soon as the balloons go down, the blood pressure comes back up, and basically what this demonstrates is that you can support these patients very adequately, keeping a mean arterial pressure of 100. It allows you the time to really do a complete and thorough complex revascularization.
I think that's a wonderful case example, Bill, and I think you already highlighted very well, but especially with left main intervention, for us to be able to give patients durable results, we really need excellent stent apposition. We need the stents to be well sized. And to achieve that, obviously intraluminal imaging is now the standard of care. There's a paper in CCI showing that it actually takes as long as 100 seconds to fully inflate an 18-millimeter long stent. Now, I don't think many people are putting up balloons for 100 seconds in the left main, but something longer than the 5 or 10-second inflation, which we sometimes see in live cases, or as you highlighted, without support, is clearly needed to get the stent to be fully rounded and opposed. And that obviously is a huge ischemic burden to a heart that's already compromised.
Well, you can do these cases. I mean, we all kind of have gotten through, but there's no need to. I mean, especially in these complex cases, you're making life and death decisions, and you want to have the best anatomic result possible, not just to get them out of the lab, but in the long term to make sure that they don't come back with restenosis because the stent's not adequately opposed, or reocclusion, which would be life-threatening in that circumstance. So I think really for me, there's nothing heroic about not putting an Impella in. I mean, it's kind of stupid. If you need support, use it, take your time, get a great result for the patients, because we know from the PROTECT II trial that the more adequately you revascularize, the better the long-term outcome.
Yeah,
Go ahead.
I think this really hits home a point here. So a couple of things that I took away from here is that, as we said earlier in one of the conversations, we talked about the idea of the enemy of good is better. And I think the first set of hemodynamics you showed with the balloon inflation without support is a nice example of to borrow a term from other operators, of granatoplasty, where as quickly as possible you get in, you basically inflate the balloon and then you get out as quickly as possible. And as you pointed to, Seth, the idea of getting an appropriate balloon inflation, especially in some of these lesions that are calcified and require a non-compliant balloon to let it crack open that area, requires a longer inflation, a higher level of inflation, and more support. The other thing too that I'll highlight here is that this is a great example of a new era for the cath lab and a new era of hemodynamics. We had a particular case very similar to this where we were doing a last remaining vessel, had the patient essentially get the same hemodynamic response with a flat line of their arterial pressure waveform. And it was very interesting to see that when that happened, two of the cath lab staff who had recently joined our institution immediately started prepping for CPR. And because they had seen this flat waveform in the middle of a high-risk intervention, people are sensitized, we're on a support device that they may not have seen before. And they were about to start, doing CPR on this patient. The patient sort of looks at them bewildered with really basically no pulse pressure and says, what are you doing? What's happening? And I think it's a great example of that how recent this experience is, to be able to get non-pulsatile flow, adequately support your patients with a mean arterial pressure as shown here of 100 millimeters of mercury while you're doing an intervention and your patient's sitting there talking to you the whole time. It really is a great example of opening a new era for intervention.
Yeah, and I think the ability to do the thorough job, just a case I just did yesterday, for instance, a 90-year-old gentleman did not want surgery, had what looked like a bifurcating left main. We put him on support. His EF was 20. He had TIMI-2 flow in his circumflex. We dilated the circumflex, and actually it was doing intravascular ultrasound of the LAD just to size the stent, and obviously, pick the right length. And of course, it turned out that all he had was a few calcific fronds, and he didn't even have a left main or LAD obstruction at all. He ended up with a single circumflex. If we were doing sort of a hit and run, we would have given an unnecessary stent besides jeopardizing the entire procedure. So the fact you can actually do the right job as you would in any elective case.
Navin, you've said in the past, you've described the effect of having hemodynamic support on the operator's ability to think clearly. Could you just share that analogy that you sometimes have talked about?
Yeah, I think it's and not to ding operators about thinking clearly or not, but it really just takes the pressure off the environment. The pressure is off. You're not under the gun trying to do something that you know is the right thing to do, but you feel like you can't do it. You're not operating with one hand behind your back when you're doing these types of cases, and I think that's really the take-home message here. The other aspect of this too is that when you see these types of waveforms, it's really important to note that you're not using pressors here. It may have been that back in the era when you didn't have this type of support and you're doing that left main intervention, you might actually start some pressors, and you start immediately making the wrong decisions there in the contemporary era, what used to be the right decision in the prior era. And that's when you start to work against yourself in terms of achieving success with these cases. And I think what does have to occur is more exposure to our interventional community, to our non-interventional community about these cases, that we can successfully take care of these multi-vessel low EF patients. They are not in that period of non-salvageability. We can actually do great things for these patients if it's done in a thoughtful manner.
Great. Bill, thank you for a great case and another great discussion. Thank you for all on the panel.